A very good evening to all of you, and welcome back to the Rare Info series. Today, we have a very special topic that we would be discussing. Nutrition in rare disease is often a topic which we don't deal with, and we actually find it very hard to even understand about it, and it forms a very important part of rare disease management. Today we are grateful to have Mrs. Shobha with us. She is a registered dietary person. She has been working with CLOUDNINE Pan India, and she will be talking about some of these management points which we have. And without wasting much time, I welcome ma'am to our Rare Info series and hand it over to her to make her presentation. Thank you.
Thank you. Thank you. I'll just share my presentation. Just let me know if it is.
Yes, ma'am. Can you please make it full screen?
Yeah, made it. Is it visible?
Yes, it is visible, ma'am. Thank you.
Thank you. Good afternoon, and I thank the organizers from ORDI for giving me this opportunity to present this difficult topic because I was doing a lot of research about this and we rarely get these cases. Quite often we do come across some hypoglycemia in the ICUs. So with the last 10-15 years of practice, I could say hypoglycemia has been frequent in critical care areas or even in newborn babies. But congenital hyperinsulinemia related hypoglycemia is a bit challenging because the case studies are very limited. It's a rare disease like. So what exactly is this congenital hypoglycemia? I'll take you on the tour to understand the basics of this genetic disorder, and then what are the treatment protocols and signs, symptoms, etc. Then I'll take you through the diet, how we manage in case if we get these kind of clients for us. So the congenital, as the name itself suggests, congenital means it is from the birth where a gene or a gene mutation can change the disease condition or the physiological functions exactly. So congenital hyperinsulinemia is hyperinsulinemia means there is increased secretion of insulin in the body, which is not regulated by the regulatory hormones or other nutrients or biochemical compounds, which usually controls the insulin secretion in the body. When this happens in a baby, a newborn babies or little on the older side, they start having hypoglycemic events, means more number of low blood sugar events are seen when the blood sugar level drops below the normal. So this is characterized by inappropriate or unregulated secretion of insulin, which I was mentioning. But this is not the common way which we usually see in the ICUs where the baby is not fed or the time between the feeding is delayed. But this is persistent, means continuous, and if the blood sugar level goes below 50 in spite of trying to maintain it, and the number of hours, the feeding durations or the gaps in spite of maintaining that and giving adequate feed.
Excuse me, Shobha, can you just be louder? Voice is very...
Oh, sorry. Just give me 1 second. I'll just increase the volume. Thank you. Sorry for me. So what I meant is if there is unregulated blood insulin levels or unregulated insulin secretions, that can result in low blood glucose irrespective of feeding the baby under normal conditions. So this happens most of the time in babies who are born with certain clinical or disease condition within the mother, or if the baby had developed some clinical condition during intrauterine life, means within the womb of the while developing through the feed from the fetus to the baby stage. So during that stage, these changes can occur. So the prevalence rate is very less comparatively, 1 in 27,000 to 1 in 50 live births, which is very low. And usually the underlying cause is genetic mechanisms, and there are many subtypes also which have been diagnosed. And effective treatment strategies can improve the survival rate. The survival is slightly lower compared to other genetic conditions. So the defect in this, the etiology and genetics of this condition is the defect in the regulation of insulin secretion by pancreatic cells is one of the etiological cause. The primary drivers of this dysregulation is histological and genetic mutation. It is classified, traditionally it is classified into diffuse and focal forms, and there are various genes which are involved, and based on the genetic type or mutations, the type of hyperinsulinemia is diagnosed. So it could be different ones like AB, CCA, and KCNJ11 or 11, what we call, which is ATP sensitive phosphate, which the subunits we always tell like ATP is very important, or ATP phosphate pumps are important to infuse insulin into the cells. It's not always the insulin requires glucose. I mean, the glucose requires insulin to enter the cell. It is even the sodium, potassium pumps also are required to sensitize the insulin to enter into the cell. If this ATP pump or ATP potassium or ATP sodium pumps are also, like if they are also changed, or if the regulatory function is disturbed, then also you could see hyperinsulinemic conditions. Then you have blue D1 condition, where glutamate dehydrogenase, which is one of the enzyme which is involved in the metabolic functions. Also, if there is deficiency or inadequacy, that can also result in hyperinsulinemic condition. But in this condition, we always see that ammonia levels are on the higher side. And because of elevated ammonia, apart from hypoglycemia, the condition is also known as ammonia syndrome. The next is GCK, which is glucokinase enzyme, and which is one of the important enzyme in glycolysis cycle and other biochemical cycle. So what happens here is, if insulin secretion is dysregulated, this cycle would get affected. In the physiological function with glucose sensitivity is lost, and that results again in hypoglycemic events. Then you have hydroxyacyl-CoA dehydrogenase enzyme also, which is involved in fatty acid mutations, which could lead to severe forms of congenital hyperinsulinemic hypoglycemia if there is a change in the mutations. So the other genetic causes would be one of the MCT related one, monocarboxylate transporter, which is very crucial for lactate and pyruvate transport. And if there are mutations, change in mutation, that could also result in these rare diseases. Next is the encodes of uncoupling protein 2, which is localized in mitochondria, and which is very important for regulating insulin secretion. If there is mutations in this UCP2 also, which is very rare, then also you can see the CHH. So there are significant different forms of hyperinsulinemic conditions, but the most prevalent is the first one, which is almost like 60% of the cases detected are the first category of mutations, that is the ATP potassium sensitive conditions. The clinical features are the risks which for hyperinsulinemia include intrauterine growth retardation, babies which are born with growth retardation within the womb of the mother or small before gestation age, or babies which are born with congenital heart disease, or if they have a history of intrauterine infections or maternal hypertension or preeclampsia. And some of the babies of late, what we see is if they are large for gestation age, if the weight of the baby or the baby's growth is enormous for their age, means fetal growth age. So if it is more than that also, what we call as large for gestation age during the pregnancy period and the birth, if the baby overgrows, then also there is a risk of insulin hypersensitivity. The presentation of this case usually is not just hypoglycemia, even macrosomial conditions, like the baby would be a large baby and it could be difficult to deliver for the mother also. So we always look not just the hypoglycemia, even the size of the baby or the birth weight and the birth length of the baby. That is also important. And if babies are born with this condition, immediately you could see seizure conditions also, which could be due to abnormal neurological damages, or which damages can get onset. Then there could be lethargy, irritability, and poor feeding problems, which starts early in the life of the baby. And one more thing is, like, macrosomal babies are usually seen at large in mothers who are overfed. Means overnutrition where it occurs, like the mother has to eat for two babies, or age of the mother if it crosses like 30, 35, late marriages, late pregnancies, and alcohol, smoking, drugs, habits, and the other things also related to lifestyle, which can also result in this macrosomal condition, that is large babies being born to the mothers. The classic clinical presentation of this is usually seen at birth when the baby is born, and there are cutoffs like within 24 hours, within 48 hours. Cutoffs are also available to assess. And infants with hyperinsulinemia are large for gestation. Usually they are, but there are cutoffs which I mentioned, like, and there could be a severe hypoglycemic events also, which requires high glucose infusion rate of more than 10 milligrams per kg per minute through the intravenous line. The large for gestational babies are categorized under Beckwith-Widman syndrome or Soto syndrome. Small for age gestational diabetes or prenatal stress-induced hyperinsulinemia, and congenital heart disease related ones are like PSHI, that is prenatal stress induced, or Bikuki syndrome or Turner syndrome. Or dysmorphic features also you can see syndromatic forms also. So there are different forms of presentation of these conditions based on the genetic mutations. The children with diffuse form of HI are more likely to present with higher birth weights, and reduced means the maintenance of sugar also would be on the higher side at times if required to maintain hypoglycemic condition. In contrast, like 50% of these children born with IA are born large for gestation and more likely present with hyperglycemic seizures after the discharge from the hospital. So once they are managed here and once stabilized and discharged, post discharge, if the parents are not counseled adequately or not educated or not informed to manage it, hypoglycemic seizures can be seen at home also. So diagnostic approaches, various diagnostic approaches apart from differentiating hypoglycemia related to feeding issues or delayed feeding or inadequate feeding. There could be delayed feeding, inadequate feeding, or the baby's intolerance would be less. Apart from confirming that, apart from inadequate feeding or delayed feeding or late feeding confirmation, there are other blood glucose steps which are taken to assure or ensure that this is hyperinsulinemic hypoglycemia. So adequately the tests which are done or insulin tests, usually the hallmark test, it is called as elevated insulin levels, blood serum or elevated insulin levels. Then C-peptide is also taken because it's a byproduct of insulin production. And then ketones, glucose, free fatty acids, lactate, pyruvate ammonia, all these are tested because some of the byproducts, some of them lead to inadequate feeding also. And if insulin is on the higher side and glucose is not met, whatever minimum storage the baby would be having, that itself will be used for fuel in the body. So to assess whether there is ketone formation due to starvation or due to inadequate fuels, I mean to say the glucose or any nutrition source available, so ketones also would be studied there. Usually acetone is considered here, and ammonia, because if the mutation in the genes is different, then ammonia levels can elevate. So for that purpose, these are some of the parameters which are studied laboratory. Then beta hydroxybutyrate. This is also one of the ketones which is studied, and this goes little lower in case of hyperinsulinemia, but acetone levels rises, but beta hydroxybutyrate level decreases. So exclusion of the other causes of hypoglycemia, once the other causes are excluded and these genetic causes are agreed upon, then the treatment is started. Once other causes are agreed, like there are no other causes related to the hypoglycemic event, the general ones, or feeding related, then hyperinsulinemic condition is taken care. Then a genetic testing is also done. A genetic testing to see which gene mutation has been done. Once that is done and confirmed, then a comprehensive panel or usually imaging tests are also done. There are two different imaging tests. One, the most often used one is pancreatic arterial calcium stimulation test, which is usually done to confirm, or it is called as differential diagnosis to confirm whether it is hyperinsulinemia. The management strategies globally on the medical line or the surgical or other considerations are like medically frequent feeding is what is advised. Regular and frequent feeding with or without supplemental glucose is what is usually given, and then diazoxide is given to improve the calcium channels as well as the potassium channels also, so that insulin sensitivity increases and to avoid loss of function also. But the side effects of this medication is fluid retention and other problems related to bone and skin also. The one more medication which is given is somatostatin analogs are given to just to inhibit or reduce insulin secretion. The counter-regulatory hormones which usually control insulin secretion or insulin functions are the ones which are used for management of hyperinsulinemia. Not just somatostatin, glucagon, there are other growth hormones also which are used to control hyperinsulinemia. Surgically partial pancreatectomy, yeah, total pancreatectomy is done, but this could also result in diabetes state. So a baby can become permanently diabetic even if partial pancreatectomy is done. Partial pancreas is removed or total pancreas is removed. Both the ways the baby becomes diabetic. But transplant is one thing which is being considered. Stem cell transplants studies are going on. Probably that could give a positive outcome, and DNA coding studies are also going on, which might be positive in the future. So other thing is continuous glucose monitor, which needs to be done depending on the glucose trends. Then you have dietary modifications about which I'll be speaking, and management of complications. Those complications which rise because of this HI should be managed in a very strict way so that the baby does not develop any seizures or growth delay should not, or developmental delays should not happen. The strategy in diet standard guidelines says is like high fat, low carbohydrate diet, but that doesn't work out in many of the babies' conditions. So long-term management of these babies would be mainly for maintaining hypoglycemia, not just maintaining hypoglycemia, and even preventing the severity of hypoglycemia, and events, the number of events of hypoglycemia also should be prevented. That is one thing. And there should be promptness in the treatment also, and if any complication arises, that also needs to be prevented, or risk management should be, you need to work on the risk and see if there are any complications or risk of any complication. That also can be addressed or prevented through diet. Then patients with well-controlled hyperinsulinemic cases can definitely look for significant, if there is no significant improvement, then neurological condition can occur. If it is well controlled, well managed, neurological growth and quality of life can definitely be optimum or better for many of these kids. So if it is severe or poorly controlled, then there will be risk of neurodevelopmental delays in cognitive, motor, behavioral, and seizures can be seen as one of the main complications, and which is closely monitored regularly. Cerebral palsy conditions can be seen, which can cause damage to the brain also, and diabetes, which becomes a long-term complication if pancreatic surgery is done. So the main concept, the main agenda of today's presentation was to speak about nutrition management of congenital hyperinsulinemic hypoglycemia. So this nutrition management is usually done either orally or enterally or parenterally. So let's just see how it happens. So before doing a nutrition intervention or starting a nutrition for a baby, there is something called nutrition assessment. It's a comprehensive assessment and it has to be done completely. There are tools available, as well as the components of the tools also tell whether the baby requires what amount of nutrition, whether it should be given orally or enterally or parenterally. Even if it is oral, what form, what route, what should be given, the composition of the feeds. Similarly, in enteral and parenteral. Enterals are the tube feeds which we usually do in the ICUs, and parenteral nutrition, which is given as a IV nutrition. It could be partial or total, or it could be central or peripheral. And OG tubes also, even the tubes could be different ones. It could be orogastric tubes, nasogastric tubes, or if it is a long-term feeding requirement or management, then you may go for percutaneous endoscopic gastrotomy tubes or jejunostomy tubes, depending on the requirement. So nutrition assessment has to be very comprehensive, so you don't put the baby into any further complications. Whatever the current condition is, that needs to be maintained well, and preventing further complication has to be done. So prevention protocols should be in place. So assessing a baby requires growth charts. You use standard growth charts for full-term babies and Fenton growth chart for preterm babies. And the component should be like weight, length, head, chest circumference, plus mid upper arm circumference. All these are very important to monitor the weight and to insulin sensitivity also, plus how many grams of carbohydrate should be fed for the baby, so that you maintain the blood glucose levels without additional increment on the insulin or the other counter regulatory hormones. So I was like input output chart, which also states as the fluid status. Fluid status needs to be looked at because dehydration is one of the risks. And if there are elevated blood sugars, or if the baby goes into hypoglycemia, dehydration risks or dehydration risk would be on the higher side. So to prevent that, input output chart. So what goes in and what comes out has to be maintained. And then blood pressure, temperature, respiratory quotient, all this needs to be maintained, because temperature is one thing. If these babies develop some infection or their temperature rises, the hydration status reduces and you need to hydrate the baby. And per kg body weight, the requirement for energy increases in babies. If the temperature, in any person for that matter, if the body temperature rises. So if you are not meeting up adequate nutrition, again the baby can go into hypoglycemic events. So to prevent that also, you need to look at even the vital signs also. The respiratory quotient, to see that which nutrient is getting used, whether it is carbohydrate, fat, or protein, which nutrient is getting used. To understand that, you need to know about the RQ also. Then if there is any risk of organ related failure, whether this condition can lead to any organ failure or comorbidities, seizures and cold extremities, etc. These things also should be assessed while doing nutrition. Then labs, as usual, apart from the blood counts, anemia, check for anemia or iron studies, carbon dioxide load or the blood gas analysis, sodium, potassium, calcium, all these are required. Then along with that, you need to look at the growth hormones, insulin, glucagon, plus these hormones are just like not just the growth hormone, insulin and glucagon, there are other hormones also which are very important to look at. One more is the somatostatin and the pituitary hormones also, so that blood sugar levels can be maintained adequately, along with controlling insulin dysregulatory functions also, if wherever it is feasible. Then lipids like triglycerides and total cholesterol should be taken care, because if baby is not fed adequately and if hypoglycemia events are frequent, there is a risk of losing weight and breakdown of whatever little fat store is there, resulting in triglyceride elevation. Apart from that, if blood sugar is uncontrolled or if insulin levels are on the higher side, there is a risk of more fatty acid metabolism. So that also needs to be looked into. And cholesterol can elevate, and lower levels of cholesterol could become one of the problems also. Then acetone, which is required to maintain, prevent ketosis or body weight loss, can also be taken care of. If fat metabolism is there, fat breakdown occurs, then ketone studies need to be done. Then what are few of the signs, symptoms which you can look for the baby in case of hyperinsulinemia, apart from the lab works, is like shortness of breath, cough, nausea, vomiting if the baby does. Nausea may be not visible in newborn babies, but babies slightly on the elderly, like infants with more than 1-2 months, you can definitely look if they have nausea, vomiting, dyspnea, and hypercapnic conditions. And weight loss, if you're feeding more of carbohydrate, there is risk of elevation of carbon dioxide in the blood. So hypercapnic condition should be looked at. And weight loss, if blood sugars are not controlled, growth of the baby and development of the baby can be delayed or disrupted. So weight changes is very important. So close monitoring is important for that. The nutrition concerns would be the major one is the hypoglycemia. Apart from that, if there is tube feedings, risk as aspiration risk, then positioning, if there is any position change for the babies, then ventilator supports, then deranged ABG analysis, the arterial blood gas analysis, or risk of sepsis, septic shocks, and reducing oxygen diffusions, increasing pulmonary load. If you're going on giving more carbohydrate to manage hypoglycemia, these are the other conditions which could become a complication for this. Apart from this, if you are feeding more consistent or heavy load of carbohydrate to manage, or glucose to manage hypoglycemia, this could also change the biochemical cycles in the body. So one should be alert about which cycle the nutrient can impact. So assessment, you can look for growth charts like I mentioned, then a comprehensive assessment taking birth weight, the percentiles or the height, head length, circumference, something like this. Charts can help close monitor the babies and prevent any complications, or overfeeding or underfeeding both can be controlled, which is very important. So what actually is being given, what is not being given within the last 24 hours, yeah, per kg body weight, if you are giving 5 grams of carbohydrate, all those things can be given. If there is any parenteral infusion or enteral infusion, whatever is done, those can be added over there. And growth charts, as usual, are one of the best to monitor long duration growth, not the short one, long duration. But for short duration, immediate weight checks, daily weight checks, or length may not change on daily basis, at least weight changes you can do it. So assessment के लिए in the past 24 hours, what has happened with the baby, what is being given, whether it is parenteral or breast milk or fortified milk or preterm formulas or term milk formulas, what is given, what is the volume which is given, and what is the dilution. Means the amount or quantity of any supplements, if it is given, how much it is, what is the weight, like 30 grams, 40 grams, what is given, and what is the dilution, how many ml dilution has been done, using water, saline, or water, like 20 grams and 30 ml of water. So the dilution needs to be checked into that. And how much of this is delivered per kg body weight, that needs to be checked. Per kg body weight, how much of it is being delivered. So how many grams of glucose enters the body per kg per hour, that can be closely monitored, so that hypoglycemia is monitored, means controlled. Then calorie load, protein load, everything of the entire formulas, whichever is being fed or given for the baby, needs to be looked at. Not just the calories, even the protein, fat, micronutrients, everything should be considered. The objective of treatment in this condition, like hyperinsulinemic condition, is plan optimum nutrition based on the age of the baby, weight of the baby, the treatment protocol, the medical, surgical treatment protocol, whatever treatment protocol is there, look into that also, and then plan. Then associated morbidities, what are the other morbidities that would be present, or risk factors for any morbidities. Those things, apart from this, there are other many conditions or factors which needs to be considered. So while planning nutrition, then deciding on the route of delivery, once you understand what nutrition you are going to deliver or plan for that, then decide on the route of delivery, which route you are going to do, whether it is going to be given orally, or whether you're going to feed the baby through the tube, or oral tube, or gastric tubes, or you are going to use a parenteral route, which route you are giving, or you are going to give a combination of the orally also and parenterally also, or orally and enterally, which route you are giving, and what type of nutrients you are going to give, what is the form of that nutrient, which is very important. And always look out for the carbohydrate form, type, and the amount you want to deliver, and the associated risks, which is very important. For example, I would like to take, if you are taking food carbohydrates, that is a general glucose, your fructose or your sucrose, or starch or your lactose would be there. But if you take the same in the enteral formula, it would not be so. The tin formula which you get contains maltodextrin or sucrose or fructooligosaccharides. So the form was different. Then coming to your IV nutrition where you don't get the glucose form itself is dextrose form, D2. So it is different. So the calorie load of these nutrient is also different. So your food carbohydrate gives 4 calories while your IV carbohydrate dextrose gives around 3.4 kilocalories per gram. So there is a difference. Even maltodextrin has a different calorific value. So when you are taking these nutrients, just understand what is the type form and look out for that carbohydrate form when you are planning to use any of the formulas or any of the route for that matter. Then the type and amount you want to deliver, how much of this should be delivered and what is the associated risk. Then look for the ratios of these macronutrients, the carbohydrate is to protein is to fat also, and how this is going to help prevent hypoglycemia in this baby. So prevent nutrition or overfeeding means any related nutrition related problem should be prevented, because already there is a genetic problem, and adding one more problem should not happen, or multiple problems, because if you mismatch the nutrients, feeding or nutrition related problems can also occur with that. So to avoid that, you just have a protocol where you're going to prevent any nutrition or feed related problem. Then avoid overloading of glucose or simple carbohydrates, which is very important. Here, if it is a newborn babies, yeah, neonates or infants, you can't say that I'm not going to give sugar, I'm not going to give jaggery and all. That doesn't work out. Here, it is either IV nutrition, yeah, formula feed, or human milk supplement, your mother's milk supplement is what usually is given. So overfeeding of that needs to be looked at. Then analyze the nutrient replacements in the feeds. Once you reconstitute it and once you plan to feed throughout the day, how many number of hours you are going to feed, how many feeds you are going to give, what is the weight volumes of the feeds, or if you're planning to replace maternal milk, mother's milk, or formula feed through enteral feed or parenteral feed, that you need to look what nutrients you're going to replace or what load or volume you are going to replace in which of the route. Because if usually two routes are given, or a transition time, if the baby is on parenteral, they may transit to enteral and then transit to oral feeds. So during that transition phase, baby will be kept on IV nutrition and then transited to oral or enteral, because you just can't stop feeding the baby. It can go into hypoglycemic event. To avoid that, continuation of feeding has to happen, and transition should be like part by part, tapering, slowly tapering from 25% to 50% to 75% and then 100%. Once there is a tolerance level maintained, if the tolerance level is maintained, only then you go on tapering it and replacing the feeds. Then correcting and adjusting micronutrient supply is very important, especially those which are low and if symptoms are present like potassium, sodium and other electrolytes, then fluids, and then vitamins also, because most babies don't come with well stored micronutrients in their liver. So supplementing these micronutrients also helps improve their insulin maintenance as well as blood glucose maintenance also, but it also helps in better growth. Then collaborating with other therapies for offering diverse and specific. So what are the other therapies which are available within the geographical location is one thing. Second thing, the physician support which comes up, the nursing support which comes up, the caretakers, the counselors, the genetic counselors, etc. There are so many other people who should be collaborated, so that you offer a diverse and complete therapy for the baby. And how best the nutrition support can be coordinated among these therapies also is very important. So one more thing is like deviating once a structured nutrition plan is given, unless there is a need for a change or unless there is some concern with regarding to the nutrition, and if no nutritionist is available or a dietitian is not available, the changes in the diet should not be done without the prior intimation of the physician or the dietitian. Otherwise, a generalized concept diet would always harm the babies. That is one thing which I would like to highlight it. And while starting formulas or changing to weaning, you want to change the formula or you want to shift the baby to weaning foods or supplementary feeding or start some complementary feeding, always introduce slowly, monitor the baby tolerates this. If there is monitor for any food intolerances and how well the baby adapts to these feeds, plus the physiological and biochemical conditions, how they adapt to the feeds. That is also very important. And what is introduced is also equally important. Addressing common nutritional issues like frequent infection, GI concerns, thyroid, and other allergies can also be taken care of, because some of these babies start developing other nutritional related or sometimes physiological related concerns. So that also needs to be looked at. And if there is hyperammonia condition, like the ammonia gets elevated, you can't afford to give proteins, too much of protein. So you have to look for what should be given and how to modify the nutrient in the diet of the baby. Then monitoring for lactose, fructose, leucemia, gluten, and casein insensitivity should also be taken care of, sensitivity. And then reducing adverse medication effects on the GI system because of this condition, to prevent any complication and to manage blood sugars, baby would be put on medication. So drug adverse reactions on nutrition as well as food drug interaction, formula feed, whatever it is, nutrient drug interaction should also be reduced. So how well one can manage hypoglycemia? One should avoid giving too much of concentrated carbohydrates, because it will counter again, it will increase the insulin secretion. As such, insulin secretion is not controlled. So giving too much of carbohydrate, again, it is going to increase demand for insulin secretion. So loading carbohydrate should be avoided, and always reduce counter-regulatory hormone response to insulin wherever it is required. So that also keeps insulin in check. Then limiting carbohydrate load to 3 to 5 grams per kg per hour within for the babies who are macrosomic or who are born large for gestation age would be ideal. And this would be again modified based on the severity of the symptoms. Then close monitor response to fats, lipids, proteins, and other carbohydrates, especially fructose, lactose, which becomes intolerant at certain stage of life, and aim for optimum nourishment so that you provide a balanced micro macronutrients and minimum deviation from the normal physiological feeds. That should be taken care of. So how much should be given for these babies becomes the question. So considering birth weight and age less than 12 months, since these babies at birth itself, it is one of the condition presented. So energy is the standard, like 100 to 110 calories per kg body weight, proteins 2 grams, while carbohydrate 5 to 7, and fat 2 grams per kg body weight, while fluid is same around 100 to 110. But fiber is one thing which usually adult diabetics it is advised, but in case of newborn babies or less than 6 months, fiber is not advised because their gut is very sterile and the digestibility, efficacy, or fermentation of the fiber doesn't occur. So the rest of the micronutrients can be given. And those babies who are large for gestation age, they should be given little lesser calories than this. That is one important thing. And babies who are born with less small for gestation age, to meet up their growth or catch up growth, it's important to give little more calories and protein. That is why you should consider the birth weight, the gestation age, and then adjust the nutrients according to the baby's requirement. And also the clinical conditions, comorbidities, treatment protocols, something which is related to nutrients, you can adjust all your macro as well as micronutrients based on that requirements or based on the conditions. Then how do you feed these babies? It can be based on the severity of symptoms. You decide how you want to feed the baby, which route you want to give, what type of feed, how many feeds you want to give, and what rate of administration it should be, how many break hours you want to give in between feeding, then how you want to prevent the complication, taking all these things into consideration. The type of feed which you would be looking for is mother's milk, formula feed, tube feed, and parenteral nutrition. Mother milk should be continued irrespective of any formula or oral route of feeding. Any route of feeding, still mother's milk should be continued wherever there is provision and tolerance by the baby. If the baby is tolerating and there is provision to feed, so mother's milk should be given. Then formula feeds, always check for the type of the formula. What is the carbohydrate load? What is the weight? Means weight volumes of the carbohydrate when it is reconstituted, and what are the ratio of the other macronutrients which can have impact on insulin as well as glucose management. Then tube feeding, oral or nasogastric, whichever it is, again look for the volume and how much of fluid is being given on the IV line or intravenous line or for medications, baby's requirement, and and tube flushes, and just manage with the smaller volumes of feeds. Then weight volumes, again the formula, the grams of formula you want to take and how much it is diluted in the required amount of fluid or dilution specific, because this can alter if less volume is taken and you add more formula, that can result in osmolarity change in the feeds, and which can cause loose stools. Diarrhea can occur in the babies because of elevated osmolarity increase. And if carbohydrate load is on the higher side, or maltodextrin, like I mentioned, is a form of carbohydrate present in this formula feeds. If maltodextrin is present, again there could be osmotic diarrhea also. So GI tolerance would become a concern with this babies. So looking into those things, then you decide what formula should be given to the baby, or how much should be delivered, and what should be the rate of administration or carbohydrate per kg per minute. Then parenterally, again dextrose load, and again it should be worked with regard to the proteins and lipids and osmolarity, and how long you are going to give the parenteral, which route you are going to give, whether you're going to give on the peripheral line or on the central line, and then how long you are going to give, for how many days, then what will be the volume, and when you are going to taper it off. Because too long lipids cannot be given for long duration, because they are one of the sources of infection. Firstly, second thing, there is a risk of elevation of blood triglycerides, and these lipids can have an impact on the liver also. Liver failure risks are on the higher side. So for that purpose, it's always good to keep a watch on these things and then deliver. And if you're giving too much of protein, ammonia levels could elevate in this baby. So very strict control and customized parental nutrition should be provided. So the best feeding options for the baby is to increase frequent feeding if the mother is feeding. Breastfeeding is the best, and the more the mother feeds, the better it is for the baby, because growth would be better comparatively. And difficulties with the babies who are finding it difficult to latch, or poor feeding problem, or and low volumes of breast milk, then interference with successful establishment can be done by lactation counselors or consultants who can train the mother for lactation and the baby also. So that can be established. If that doesn't work out, if the baby is still not able to take up adequate volume, or the mother is not able to provide adequate milk or secrete adequate milk, then the formula becomes the next choice. But again, while considering formula, one should look into the nutrient compositions, the preservatives, the coloring, stabling agents, everything, and then see how this formula helps the baby and how it will help in maintaining hypoglycemic events also, and whether it is a certified medical formula for the baby or not. Those things also needs to be looked into. And then formulas, sometimes look out for those formulas which are less expensive, readily available and easy to use, and which have slightly higher carbohydrate, but not too high carbohydrate content, maybe 5 to 10% additional carbohydrate load. If some of the formulas provide you around 30-40%, then you can look out for 50% carbohydrate load, slightly high carbohydrate load, not too excess. Then this, if that happens, if the carbohydrate load is higher than the requirement, 60-70%, that could increase rapid blood sugar concentrations. So that also needs to be looked into. And if these formulas which are containing slightly high carbohydrate, if they are diluted properly, means the reconstitution volume is slightly on the higher side, then there could be a blood sugar maintenance level can be done to an extent. And since these formulas do have some amount of fiber present in them, that can also help in glucose release, sustained glucose release. So, however, the use of infant formula is always a risk, and it is always good to continue with breastfeeding. That is the best and it will also improve the gut microbiome of the neonates. So one of the things which can prevent mother's milk is the best to prevent the infections and allergies and improve the nourishment and health of the baby. So always support mother's milk for the baby. The last options would be the enteral formulas or formula feeds or parenteral. So if the baby's blood sugar is not coming to control, recheck every hour after feeding. And if baby is going into hypoglycemic conditions, definitely dextrose gels are available and those can be used. I'm not aware in India where it's available, very less. Usually infused dextrose is infused over the IV line. And in other places where dextrose gel is available, it is massaged into the buccal mucosal cavity so that it maintains the blood sugar levels. So, what are the things you need to monitor when you are nutritionally intervening for a baby? Is sweating, like baby goes into hypoglycemia, they can definitely have sweating, feeding difficulties, poor sucking, weak or highly pitched cry, tremors, hypothermia, irritability, lethargic, osteoporosis. It is slightly on the babies who are grown, hypotonia, seizures is one common thing which you can see, and sweatings and feeding difficulties are some of the common ones we can see. Even hypothermia also can be seen in this baby. Sometimes babies go into coma, but this is little difficult to assess in the initial stages because babies keep sleeping more. So apnea, grunting, and tachypnea can be seen in little later babies, and cyanosis can be seen in the new babies itself. So what should be the checking parameters apart from this for nutritionist or dietitian is weight changes, regular weight checks, signs of dehydration, input output, vitals, blood sugar, triglycerides, and ketones. So if your nutrition intervention is right and it's going on properly and the baby is getting adequate nourishment, then these would be in a positive state. The weight change would be positive, at least 20 to 30 grams of weight gain can occur in the baby. Reduced signs of dehydration, baby will be well hydrated, input output will be balanced, and all vitals like the heart, temperature, everything would be near normal. Blood sugars will be well controlled, and triglycerides and ketones will be absent, and triglycerides will be within the normal level. So, congenital hyperinsulinemic hypertension, it's a complex and challenging condition. It requires multidisciplinary approach and in diagnosis and management. It is not like alone a pediatrician or neonatal will manage or alone a nursing will manage. It's a multidisciplinary team approach where lactation consultant, nutritionist, mother, father of the baby, plus the physicians and the nursing care, everyone, genetic counselors, everyone should be involved in this. Then nutrition plays a very important role in managing and optimum growth and improving quality of life of the baby also. Then advance in genetic testing is happening, imaging testing needs to be done, and medical surgical therapies are proven to improve the prognosis of these affected individuals. So these can also be used. So early recognition and prompt interventions are the ones which can help in long-term neurological complication preventions. Then continued further research can be done to improve good studies and treatment protocols. So though there is, despite the future direction should be regarding identification of novel genes which can help and treat and manage diagnosis and treatment. Then developmental of non-invasive techniques which are very important rather than invasive techniques. Then novel therapeutic strategies can also be done with medications or other insulin signaling pathways which can also be taken care of. Long-term follow-up studies are very much required, and most of the times we lose connect with the patients because they keep shifting from one physician to another physician, or one treatment channel to another treatment channel, thinking that the other treatment would be the best, or camp therapies which could be best, and that is how we lose the baby. So parents should be educated, means counseled and educated that change in therapies is not right. Thank you. Thank you for your patience listening.
Thank you, ma'am.
Thank you so much for that wonderful and crisp presentation. And
Sure.
there was so much learning points. I have a few questions from my end.
Sure.
And ma'am, one part would be we do have a lot of nutritionists, but the training about what you said, the clinical aspect, the metabolic aspect. If you could highlight this part, that how can our young nutritionist get experience and get training for these specific IEM disorders or these specific genetic disorders to have such insight? I understand it takes time, but at least the training programs, could you please highlight one or two of these training programs?
Currently, as far as my knowledge goes, very few institutes are training dietitians, yeah, clinicians for nutrition management in inborn errors of metabolism or genetic disorders. All that is done is only from Western countries. India, may we usually, I'm not seen in India. Really, whatever we are picking up, the information is from the webinars or conferences, etc. But here in Cloud9, we are coming up with some programs and certificate courses for inborn errors of metabolism with 20 different case sets we are coming up. And we'll be releasing some book and sessions on this also. Shortly, I'll keep you posted. But countrywide, I've just checked up with AIMS and other institutions. They are not doing any specific training. In the case based, they are doing it. I'm sorry to say that that is the state of things.
No, I understand. And this is a problem which we also have while we refer to nutritionists, but the actual people, the actual skill in, actually controlling these, we have very few people across India, and it becomes very difficult. My, like some questions would be like because we were talking about congenital hyperinsulinism. So, ma'am, we have majorly two genes over here, the ABCC8 and KCNJ11.
Yeah.
So in your experience, ma'am, is there any impact of, what kind of gene is there to the to the strategies, or it is just that if they have these kind of disorders, then this would be the management? Is there any mutation specific nutrition strategy?
Yeah, in two conditions we see that. One where we see the first condition, what you mentioned, the ABCC8 in that condition, the strategy would be mainly to focus on the carbohydrate load and hypoglycemia management, first thing. Second thing, growth failure or delayed growth can occur. So we try to see that the growth should be optimum, catch up growth, whatever happens. But these babies who are large for gestation age, those babies, it is little difficult because we don't want the baby to lose weight just because we want to control the blood sugars. And that is one thing. And the next thing is like the other condition where we see hyperammonia condition where the blood ammonia levels get elevated, and we find it difficult in such a case because we want to give high protein for the baby. Babies require little higher protein, and there is hypoglycemia also and ammonia load also. Sorry, hypoglycemia and ammonia, both you need to. If you increase too much of carbohydrate load, the baby's blood insulin requirement surges more, and again hyperinsulinic condition does not come to control. And if you increase protein load, the ammonia load will not be controlled. So there are conditions like this based on the genetic change or the genetic trigger for the hyperinsulinemia. The treatment, especially the diet, macronutrient variation is more, and even sometimes micronutrients also. The first variation which I mentioned,
So that means
then
when a person is actually coming to you, the mutation reports are also important for you to,
yes,
rather
yes.
than just a diagnosis of like if we are talking about hypoglycemia.
Yes, yes. We do request them to show if any genetic detailing has been done so that we understand which cycle of the nutrition is biochemically affected. Then how we change that, or how we look into catering that nutrient. Or for example, if I take phenylketonuria or any other cycle, if you take the enzyme which is required for the next step, if it is disrupted or if it is not able to be processed, the next step in the biochemical cycle would be hampered. So that nutrient which cannot change itself or get changed into another nutrient, which is very important, then we look out for other ways where we can provide, or any other cycle which can bring in that same nutrient or same biochemical compound. So that for that purpose, at least we require this genetic mapping done for these diseases.
Now, many a times initially there is NG tube feeding for the infants, and these NG tube feedings can also create a lot of issues, like for if we are doing it continuously. So, what do you think are the pros and cons of continuous enteral feeding versus bolus feeding with respect to CHI?
Enteral feeding, it can be controlled, well controlled, provided you have a good skilled dietitian and a physician and supporting nurse, because these are very important there. So if the nursing and the physician and the dietitian are synchronized and the multidisciplinary team is well established, so you can definitely have no complication in enteral feedings. Because we keep doing it. I have an ICU next to me. We do a lot of ICU babies on enteral feeding, preterm babies born with some complication. So what we do is we monitor, we put a strategy like these complications should be prevented, aspiration, and feeding, the way the rate of infusion, whether you are going to do a gravity feeding or you are going to be a bolus feeding. Bolus feeding usually we don't do for the babies because they need little time to digest, and the stomach as a reservoir in babies is little very small, and we don't want to push too much into that. That is one. And the colic complication which can arise with these babies also, and that can be one of the trigger for aspiration, micro or macro aspiration. So to prevent some of this complication, and while positioning, shift of the tube or dislodging of the tube, to prevent all these things, we go slow with the babies. We give gravity feeding for the baby, or we do something called as infusion sort of thing through the syringe infusion. It goes like 1 ml per kg or per hour, that way. So complications can be prevented with enteral feedings, and you have a very tight control of what all nutrients you can give, what should be the composition of the feed, how much of fluid you can give. You can modify that and customize it as per the baby's requirement. But if you're giving a mother's milk, though I promote a lot of mother's milk, still you can't change the composition of the mother's milk. That is one thing which uh, is a bit challenging sometimes.
Yes, ma'am. Thank you for answering that one. Very, I think it's a naive question, but I'll still ask because many of our nutritionists keep doing it. Role of uncooked cornstarch or similar kind of agents when we are treating like for children with CHI.
Uncooked cornstarch you can give if the babies are slightly on the older age, above 6 years and 6 months plus. But for baby which is newborn, you can't. Sorry, for a baby which is newborn, you can't give cornstarch and other things. They try it out, but there are other complications which we have noted. So I usually don't recommend it. Uncooked cornstarch in hypoglycemic events, in other inborn error conditions, you can definitely give it, provided at least the baby should be above the age of 3 to 4 months, where the gut is physiologically better digestibility, better tolerance. So this is usually given in the middle of, around bedtime, so that overnight hypoglycemia, early morning hypoglycemic events can be prevented. But uncooked starch, I usually, or the cornstarch, we usually don't recommend because babies' digestive enzymes are not that good enough, is what we have noticed.
Okay, ma'am. Thank you so much. One last question because we have 2 minutes, but it's a bit of a difficult question. Like, this is something that we face. Sometimes the children have pancreatectomy, and then the nutrition has to be adapted. So, especially with the risk of iatrogenic diabetes. So, in such cases, how would you how would you scale up, scale down, or change the diet?
If pancreatectomy is done, means removal of the pancreas, all three macronutrient metabolism will be affected. It's not just carbohydrate, even protein, fat, because pancreas is one of the organ which takes care of metabolism of all three macronutrients and enzymes and hormones also. All the hydrolytic enzymes from the kidney would be. Then if it is partial, there is a chance it can be maintained still. But if it is total pancreatectomy, the growth and development of the child will be hampered. But nutritionally, what we have to do is sometimes they do give pancreatic enzymes, and they will definitely become type 1 diabetes. So insulin and diabetes management becomes one of the core management area, where it's almost like treating them as type 1 diabetes. But proteins and fat digestion also will be affected here. Apart from bicarbonates issue, there are other clinical things which also gets affected because of pancreas. In this condition, what we do is we give them small meals and something called as isocaloric and isocarb and isoprotein load. Means each meal should have almost a measured amount of calorie, measured amount of carbohydrate, and measured amount of proteins, so that it does not go above the range. For example, if you are taking 1,500 calorie diet, it will be split into 5 to 6 meals.
Hello.
So each meal should be somewhere around 300 grams, and within that 30-40% range what we want to give, that amount is what is mentioned, along with fiber load and micronutrient supplement. Pancreatectomy itself is a different scenario here, and
Yes,
babies will become type 1 diabetics for life.
yes, ma'am. Yes, ma'am. Yes, ma'am. Thank you so much for this insightful discussion. We have come to the end of today's session, the Rare Info series. And today we dealt with one very important aspect, which is nutrition in CHI. And we thank Madam for giving us such a great insight into this. And we hope the Cloud9 nutrition education for the nutritionist opens up for rest of the country, and we can train the skilled workforces for the same. And with this, we end our today's webinar. We will be back again at the same time next Saturday, 4 p.m. with another very interesting aspect of Red. This. Till then, stay healthy, stay safe, and a very good evening to all of you, and have a great weekend. Thank you. Thank you all.
Thank you.